I want to thank you all for joining us this evening. My name is Dr. Rachel Hart-Earls, and I am a medical science liaison with Myriad Mental Health, the makers of the GeneSight test, and I will be your moderator for this evening. Few housekeeping items. If you have questions, please let us know. We ask that you put them in the Q&A feature, and we will do our best to address all of them. But if we run out of time to answer any of them, we will follow back up with you after the webinar to ensure that we can answer your questions. As you all know, July is Minority Mental Health Month, and research shows racial and ethnic minorities experience poorer health outcomes in the United States. Tonight, our panel of healthcare providers and GeneSight experts will share practical approaches for improving racial health equity in mental health care settings, including recent research presented at the American Psychiatric Association's annual meeting, showing patients who received treatment guided by pharmacogenomic testing showed improvements in clinical outcomes regardless of self-reported race or ethnicity. We hope by the end of this webinar, each of us can have a better understanding how to, first off, acknowledge how generations of mistrust of the healthcare system and underrepresentation in clinical trials contribute to poorer mental health outcomes for racial and ethnic minorities. Secondly, we hope that you learn how the GeneSight test can be used as a bias-busting tool in mental health treatment. And lastly, we hope that you will understand the findings from a new research analysis of the guided study on the clinical utility of the GeneSight test in diverse patient populations. I'm thrilled and honored to introduce tonight's panelists. First, we're going to start with Dr. Gus Alva, a distinguished fellow of American Psychiatric Association and the founder and medical director of the ATP Clinical Research in Costa Mesa, California. Welcome in, Dr. Alva.
Thank you for having me, Rachel. It's a pleasure and an honor.
Good, we're thrilled to have you here. Next, I'm going to introduce Dr. Johnny Williamson, owner of Spectrum Behavioral Health in Hinsdale and New Lenox, Illinois. We are so glad you are joining us, Dr. William. Thank you for being here today.
Thank you, Rachel. I'm happy to be here.
And last but certainly not least, Dr. Morgan Saulsberry. Dr. Saulsberry is a senior medical science liaison at Myriad Mental Health, and I am proud and honored to call her my colleague. Welcome, Dr. Saulsberry.
Thanks, Rachel. I'm glad to be here as well.
Good. So let's go ahead and get started. I'm going to start with talking about some statistics and data that we know about health equity. The Center for Disease Control, or the CDC, states that racial and ethnic minority groups throughout the United States experience higher rates of illness and death across a wide range of health conditions, including diabetes, hypertension, obesity, asthma, and heart disease when compared to their white counterparts. And research in JAMA Psychiatry found that increases in mental health-related emergency department visits were notably higher among racial and ethnic minority groups during the pandemic surges, suggesting many things, but first off, that there is a need for better proactive, preventative mental health care for these patients. The authors of the JAMA study that I just mentioned note that race and ethnicity are related to inequities in hospital care and mortality, and that stigmatizing experiences and other factors can lead to a general mistrust in the healthcare system. So I'm going to start with you, Dr. Alva. These findings are obviously concerning, and so I'd love to get your input on what inequitable care and mistrust means for a patient who's seeking mental health. And follow up with that, have you ever experienced this mistrust that we're talking about yourself or in patients that you treat?
You bet. This is a very important topic. One obviously needs to trust to be able to accept care. And it's very easy to discern geographic and or linguistic barriers in creating a bit of a disconnect in individuals. But one obviously also needs to take into consideration multiple issues, which might include biology. I'll give you an example. When we talk about poor metabolizers of the 2D6 isoenzyme pathway, there's clearly a difference between, say, a Caucasian sampling versus a Hispanic or an African-American subgrouping. Certainly the psychology of how somebody perceives things, the social issues and the spiritual issues all encompass this very theme. But yes, the very first thing that's needed is to trust to be able to accept care.
Absolutely. So I think you put it very well that this is a multifactorial issue And especially when you're treating mental health, that is also a multifactorial issue, which can almost exacerbate the situation. Dr. Williamson, do you hear concerns from patients about barriers in their ability to seek treatment?
Yes, unfortunately, I hear that quite often, and as you might imagine, that the numbers of potential barriers are high. And I think specifically for ethnic minorities, there are some that are very specific. And so starting from even the idea that treatments can be effective and can be helpful, I think that there are ways in which there isn't as much information and education that's spread amongst communities equally, so that people do know that there are known effective forms of treatment. I think other concerns include stigma, mental health stigma, and concerns about perceptions of others, and even perception of self. And I think in addition to that, you have concerns about running into bias. I think bias is something that you learn to live with, that you encounter in multiple aspects of your life experience, and then to experience those in a health setting, especially a mental health setting, can be very off-putting. And so many of those things can lead to a level of skepticism about how they're being perceived, or how what levels of care and how good the care actually is that we are receiving.
So this may be a difficult question to answer, but why do you think, you mentioned that specifically there are these barriers in mental health care settings. So why do you think there are more barriers in mental health care compared to other fields of medicine?
Well, when it comes to mental health care, I think it's true in all areas of health, but specifically in mental health, there is a connection of understanding and communication that's really important. Again, that's true in all areas of medicine, but to be able to understand and to be able to communicate understanding of a patient in a way that they can feel heard and understood is really vital. And it requires some level of experience and technical knowledge around the illness state, that individual, and then other norms and values of the race and ethnicity of the individual that's seeking care. And so if you are missing some of those elements, it starts to chip away, whether it's conscious or not, at that bond, that trust that we're calling trust. I also call it skepticism, because I think a lot of times when you're coming in new to receive care, you're trying to figure out, is this okay? Does this make sense? Is this going to help me? May it hurt me? Does this person understand and hear what I need? And can I trust what they're offering?
Absolutely, that makes a lot of sense. And I'm going to turn it to Dr. Saulsberry. Dr. Saulsberry is a pharmacist by training. So obviously wears many hats as a pharmacist, but prescription management is the first and foremost that I think of. So did you see any hesitancy in different populations when seeking different medications for mental health treatment?
I mean, I would say from the get-go, you definitely see fewer Black patients and even Hispanic patients seeking actual medications in treatment. A lot of the times they'd be there for a different type of visit. And then that's kind of when the issue of mental health will arise. And then they may be prescribed that medication, they may not choose to take it. So non-adherence exists in all different types of populations, but it's definitely still an issue with minorities as well.
Thank you. I think that's good to provide another perspective as well from a different area of medicine. We know that the CDC defines health equity as being achieved when every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So this is a very broad, big question, but I'll start with you, Dr. Alva. What does health equity mean to you?
I would definitely say it's the opportunity of addressing health disparities, right? And as Dr. Williamson so eloquently put it, there's a big difference oftentimes from a socioeconomic perspective. The education that you have about a given topic will vary greatly. And if that same education isn't being distilled across different groups, and that's not necessarily such a great thing. The opportunity for being employed obviously keeps you out of poverty. And as a consequence of that, also allows you the opportunity of being able to access preventive healthcare services, which are really at the base of everything that's needed. Certainly lifestyle behaviors, such as physical inactivity or alcohol intake or drug use are going to be damaging to individuals, but people just need to be fostered the appropriate information, the social environment in which one resides, and certainly, another very important point, the racial or ethnic discrimination that sometimes abides, whether that be conscious or unconscious, certainly drives at certain scenarios where individuals don't necessarily have the same opportunity. So forums like what we're doing right now allow an opportunity for really being able to take a look at how we might be able to bridge some of the divide that currently exists and how to best correct it.
So I think you pointed out multiple excellent points, but the one thing I want to hone in on there is the role of the healthcare provider in bridging that divide. So Dr. Williamson, can you maybe talk about how healthcare providers have a unique opportunity to help with the education and help discuss maybe the gaps there?
Well, yes, I think it's very important to have our healthcare providers be active participants in engaging in activities that help bring awareness to this concern. I do think it's a problem that's multifaceted and involves most important elements of societal functioning, whether it's housing, income, wealth, transportation, education, and the like. Many similar things that Dr. Alva correctly pointed out. And so I think that as ambassadors of mental health care and healthcare, I think it's important for us to find opportunities to discuss these issues and these concerns, and to lend our knowledge and experience to try to get action on some of these very difficult aspects of the problem.
Thank you. Thank you for sharing that. Dr. Saulsberry, I'm going to turn to you. So as I mentioned to the group, you are a pharmacist by training. Part of the role of a pharmacist, as well as the role of a medical science liaison, is to be well-versed in research and literature surrounding certain areas. So in this instance, it's pharmacogenomics. So I kind of want your perspective on health equity from the research side of the coin. So, we talked about clinical practice and where we see those inequities play out, but what do you see in the research about health equity as well?
Yeah, absolutely. I think when it comes to research, it's very important that when we're showing treatments are effective, that we're showing that treatments are effective for all people, not just for a certain race or ethnicity. So it's important that when we're doing trials to make sure that we have a diverse population in order to make sure that those endpoints and those outcomes that we're looking for actually translate across all those different populations. So I think that's what health equity would mean in the realm of research, is making sure that the treatment is effective for all.
And for those who aren't as well versed on the research world, is it unusual for there to be small proportions of minority ethnicities in clinical trials, or what is the norm that we see in most clinical trials?
Yeah, I would say, unfortunately, it's not uncommon that a majority of a cohort or a group that we're following may be Caucasian. However, I think, as Dr. Alva mentioned, we're focusing on ways that we can combat health disparities. And I think this is something that's really come to the forefront, especially this year. I know I just attended the APA conference, and that was a big topic of discussion, was health disparity. So I think we're going in the right direction of having the idea that we need to have more diverse populations when we're looking at different drugs and new treatments and things like that, just to make sure that we are able to truly speak out that this is going to be effective for not just one group of people.
And I have a question about, and there may not be an answer, and this can go out to anyone. Why have there, and I asked this a little bit of Dr. Alva earlier, maybe, why do we see these health inequities and, education gaps in practice, but why do we see decreased minority groups in clinical trials? Is there a reason for that? Is it sampling bias? What is the reason that we're seeing these discrepancies?
I'm going to have to borrow Dr. Williamson's previous term of being multifactorial, but that's exactly what it is. If you can't address somebody in, say, from a linguistic perspective, right? If their native tongue is Spanish, and you've only got rating scales that are being done in English, and obviously that's going to create a disconnect. So it's a very obvious situation that if you don't have the appropriate amount of professionals that can, again, reflect back on the individuals who may be participants in a given clinical trial, then obviously you're going to be limited just by that. It's not just we're intentionally keeping different ethnic groups out. Historically, there's been a situation where different racial groups, certainly, like for example, African Americans, there was an infamous type of a project that specifically looked at syphilis and allowed individuals to stew into not just primary but secondary and tertiary syphilis. That whole Tuskegee experience had left a bitter taste in a lot of people's mouths, and a travesty that was allowed to move forward. So that's created a great degree of mistrust in individuals, and it may be that institutional memory that's again, shared by different generations and different groups. Obviously, that doesn't necessarily impact as much now per se, but there are still different types of limitations that keep individuals. So if we're truly being honest about this situation, you don't always have the ability to be able to bring in everybody. You try as best as you can. And what we're doing now is really fostering that opportunity to really encompass as many different individuals as possible, because in the real world, we end up treating everyone, not just one group.
I'd also like to add, I think I agree with all those comments. I mean, I think the history there is something that we have to actively work to overcome. For obvious reasons. And I would also posit that, similar to the difficulty in accessing care in these populations, the fact that there's a separation between these populations and healthcare providers and the research institutions. And I think the same difficulty that they have in reaching us because we're not in their communities, the reverse is also true. And so I think in the processes that are in place, and I know there are a lot of efforts oftentimes to create a more diverse sample for research studies, but I think we experience that same difficulty in access in reaching those individuals, even if we could get them to trust us to participate in the studies as well.
And Rachel,
Absolutely.
if I could just chime in one last
Please.
thing you
Yes.
mentioned of, mental health and just general health, and everybody, for the most part, will oftentimes view a mental disorder as something different than a general medical condition, when in reality, it is a general medical condition. And one of the things that we oftentimes try to dispel is to let people know, look, if you allow your blood pressure to be going up constantly, you might end up stroking out. You might end up with half of your body paralyzed. Do you want that? Well, no, of course not. Okay, well, then that means you're going to have less salt intake, physical activity, and make sure that your blood pressure is kept under tight control. Same thing with diabetes. Do you want to end up blind, your kidneys blown out, painful diabetic peripheral neuropathic pain? Well, no, of course not. Well, great. That means you're going to have good, tight blood sugar control. And that's why we're doing this, but we're not curing those problems. We're just controlling them. Well, sometimes people can't necessarily equate that major depressive disorder, bipolar disorder, a generalized anxiety issue is exactly the same thing. And they think that, oh, wait, there's disparity even with that, right? When in reality, it's the same thing. It's just a medical condition that needs to be treated appropriately.
Dr. Alva, you hit on such an undertone of many of the webinars that we've given that for some reason there seems to be a disconnect where people think disease of the mind is separate of disease of the rest of the body, when in reality the brain is the most complicated organ we have. And so it's almost like they need permission to let themselves accept that they have a clinical condition. And so I think that is a barrier to treatment. It's a barrier to talking about it. It's a barrier to a lot of things. And so if there's one big take-home message that I think we try to drive home, is that this is an integral part of your health, because it doesn't just affect physical, physically how you feel, it affects every part of who you are. So, I think obviously I have a bias towards proactive mental health treatment, considering the field I work in. But when you think about it from that perspective, I think it should be highest priority in things that you choose to treat or choose to seek help for. So thank you for sharing that. And I obviously share the same viewpoint as you on that. I want to turn it over to Dr. Saulsberry. So I want to talk about implications for the GeneSight test and the new research analysis from the guided study that you recently presented at APA. I'm going to share my screen here, but as I pull that up, Dr. Saulsberry, just in case there are people on the call who are not familiar with GeneSight, if you wouldn't mind just giving a 100-foot overview of what GeneSight is, and so that way they can have a little bit more context when looking at this data.
Definitely. So GeneSight is a pharmacogenomic test that essentially it tells your doctor what you can't. It basically shows them, things from your DNA. So essentially it's telling your doctor how you may respond to medications or how you may break them down or metabolize those medications. And so the study that Rachel was referring to was the guided study, and that was one of the most pivotal studies that we've had to date in mental health. And what it was trying to discern was looking at treatment outcomes of response, remission, and symptom improvement. And we saw some really great things from guided, but when we're talking about, health equity and diversity, the one thing about guided that had its limitations is that it didn't have a overall very diverse population. So this study that you have up on the screen actually was a post hoc analysis from guided. So we wanted to look just at that population of Black and Hispanic patients that participated in guided, just to make sure that we were seeing, similar results when it came to those endpoints in regards to those populations. So that was kind of the backstory of how we decided to do this analysis.
Thank you so much. So as Dr. Saulsberry mentioned, this is one of the largest clinical trials of its type to look to see if having access to the GeneSight test led to changes in clinical outcome compared to the standard of care. So no placebo, 2 treatment groups. And so this was a poster that was presented by Dr. Saulsberry at the American Psychiatric Association annual meeting. So this is new data. And so I'm going to go ahead and turn the floor over to you to share this data.
Yeah. So really what we saw from this was 2 main things. So the first figure that you have up was on medication distribution. And really what we saw is that for Hispanic patients and Black patients, that there was a similar amount of patients who were on what we would call these red category medications. And those are medications that have significant gene drug interactions. So if you look at those 4 red boxes, they're pretty similar in number. And in fact, they're pretty similar also to what we saw in the overall guided population. So this is really good news because it means that, we're seeing the same thing across populations. The second thing that we saw from this poster was that when we looked at the actual outcomes of symptom improvement, response, and remission, what we saw is that for the PGX arm, so basically if a clinician had access to GeneSight, we saw that there were higher improvements for all 3 of those endpoints compared to a clinician not having access to GeneSight or to genetic results. So that's the PGX arm compared to that TAU, which is treatment as usual. And so this is great news as well, because it's showing that both race and ethnicity did not actually play a role in terms of making it more effective. There was no difference in those results. And I will point out that this did have a very small sample size. So a lot of these numbers were not statistically significant. But I think that really just points out to the fact that we do need to do more studies that have more diverse populations so we can make sure that this data is statistically significant and we can see that this carries forward in future studies.
Thank you so much, Dr. Saulsberry. So if I can try to take your words and kind of spit it back out in a few sentences here, this poster shows that regardless of race or ethnicity, the effects of using pharmacogenomic tests were consistent. And when I first saw this poster, I was really excited by the data, but I just thought in my head, like, hasn't this been done before? And Dr. Saulsberry, can you point to the novelty of this as well?
Yeah, so this has never been done before, actually. There's no previous studies that looked at this. So this was really fun data to present at the conference.
Yes. So I am going to stop sharing my screen now. And I would like to turn it over so Dr. Saulsberry, excuse me, discuss GeneSight as a tool. So it is a medication selection tool that looks at your patient's genetic makeup and how that can help with medication selection. So we've looked at that from a research perspective. It's been very well studied, but I want to shift gears a little bit and talk about it from a clinical perspective. So how do you actually use the test? What does it look like in your day-to-day practice? So Dr. Williamson, I'm going to start with you. You have used the GeneSight test in your practice before. What were your first reactions when you saw the data we just shared? And had you ever considered using the GeneSight test as a tool for mental health equity before?
Well, I'll tell you, when I first became aware of GeneSight, I was really excited. I think the work that we do when it comes to medicating patients within psychiatry and mental health, there's a lot of subjectivity. I mean, hopefully well-trained and well-intended, but we don't have a lot of objective measurables that we can utilize. And so to see GeneSight as a tool that we could use to understand, one, how the gene-drug interactions can occur within a patient, and also how their body may likely metabolize the medicines, and to be able to use that to kind of understand what their responses to treatments were, what are things that we should probably be more careful about or thoughtful about, was really refreshing. And I'll tell you, when I share the information about GeneSight and how it works and how to understand it, many of my clients or my patients are very happy to kind of get that understanding. It's something that they can grasp onto and understand why we're making the treatment choices we're making, and also to prepare them for evaluating their response to the medications. And then when they come back, we go back to the drawing board and see what the results were, and then continue to use that information moving forward. So it's been a great tool. And again, its objectivity helps us to use objective data where we otherwise might use our own subjective perceptions. And so I do think as well, this is an opportunity to limit the impact of certain kinds of biases in our perceptions, because we're able to use objective information to make clinical decisions.
That's wonderful. And I think that's such a good point about reducing the subjectivity to help reduce bias as well. Do you think that having this objective data also helps with potential ambivalence about medications?
Absolutely. I've been able to use that information to help some folks who were reluctant to try medications. And so when talking about side effects or the likelihood of side effects and how it might affect them and things like that. And so we talk through all the things that are relevant to know about the medicines and the condition we're treating. But then I can also say, hey, we'll do this test and I'll go through it with you. And you can see, this is where how your body manages these particular medications, this group. And so I really think that's helped people to be, to feel like they're making a decision based on some information that that's a bit more objective, which can make it easier for them to feel comfortable with what we're doing.
Dr. Alva, I'm going to defer to you as well for the same question.
Dr. Williamson was really eloquent with how he stated that. That's typically the approach that I'll use with patients also, and let them know that just like we check to make sure that they're not anemic or they don't have an endocrinopathy if they happen to be depressed, because those are easy things to fix. We want to make sure that we don't necessarily err by not necessarily checking for one thing. There is no end all be all test, but this is actually a really cool test. So the GeneSight test does allow us additional objectivity so as to be able to figure out, how we might be able to help out our patient in a better manner. One thing that you made mention of earlier, which really sticks, is that you mentioned this as a bias busting tool. I kind of like that. You need to coin that, because we can all apply this help to address all the very issues that we've been addressing right now. Just the very concept of genomics that are being utilized to improve depression decision-making, in this whole trial, and the attempt of really trying to pierce through the veil of unlocking why it is that we've got this disparity that exists at the present time. I think that this is really important. We should really be utilizing this test with all our patients. Again, the importance here is that it's not necessarily going to tell us what exactly we have to do, but it's going to help us so that we're not necessarily tripping over ourselves with things that are very obvious. As Dr. Williamson just right now made mention, if you can anticipate whether somebody might experience a side effect or not, you can then have a little bit more of a dialogue regarding that. Or again, if they're going to need a little bit more just based on their overall genetic makeup, well, that's an easy discussion to then have and let people know you need to be patient and we need to walk through what we need to get done. But now we have additional tools at our disposal that are not necessarily guaranteeing success, but they're going to maximize on that likelihood. And so, in joining individuals, that's, we started out by saying trust is essential, right? Well, this is one of those very ways. And sometimes people will say, well, wait, you just wanted me to do another test? And it's like, well, hang on, this is like a once in a lifetime test. It's pretty easy to do. All we have to do is a cheek swab. It's not that complicated, and it's going to give us a wealth of information that, you don't necessarily have to replicate again. And so it's kind of a no-brainer, right? It's kind of a win-win.
Yeah, and one comment I've received a lot is, as we talked about earlier, how sometimes people deprioritize their mental health because they don't view it as an actual part of their overall health. But I think using objective measures like this shows that there is a science behind what is happening. There are your genes that are affecting your response to these medications. So I think it also adds a layer there. I got a question in the chat about how diverse, quote, is the GeneSight test? Essentially asking whether this test is able to detect variants that are unique or rare to non-Europeans. Excellent question. And so we are actually in the process now of working on expanding our allelic coverage. So what that means is that we look at certain genes, and what we're really looking for are variations in those genes. So do they look different than what we would expect them to? And a lot of the data that we have used has come from an historically Caucasian population, because that's where the data generally is rich. But right now, our company has made an effort to expand the alleles we look at. So right now, they just finished reviewing 6 genes on our panel, and they're planning to bring the positive and negative findings to the science committee and working to add those to our panel as we speak in efforts to promote diversity, equity, and inclusion. And so there are many studies outside of what I just spoke of that are actually working on that as well. And there have been studies that have shown that there are differences in allele coverage based on ethnicity, based on location around the globe. And so GeneSight is working on integrating that into the panel as well. Morgan, I wanted to, oh, I'm sorry, please.
I was just going to comment on that very point. All you have to do is look at something like the human leukocyte antigen and take a look at the possibility of serious adverse cutaneous drug reactions. Now, there's different ethnic groups that have a higher degree of susceptibility to that. Doesn't mean they're deficient or otherwise. It just simply means that they have a higher likelihood of experiencing a problem. So long as you know that and you can anticipate that, you've got that dialogue beforehand. And then all of a sudden, you look like you're walking on water, when in reality, all you've done is your homework. That's it.
Absolutely. So I got another question in the chat, but first I also want, while we're kind of on this topic, to pivot to Dr. Saulsberry. So as a senior medical science liaison, one of the biggest parts of her job is education. And so she educates healthcare providers on the GeneSight test. And so I want to kind of get your perspective on how that can increase health equity as well by being able to share how the GeneSight test works.
Yeah, I mean, I think it definitely helps increase health equity because the more providers that use it in the more different locations, the more access that patients get to the test. I think that there can be skepticism on the part of both patient and provider when it comes to genetic testing. And so that's probably the most fulfilling part of my job, is being able to educate providers about what GeneSight can do, and then also share the data behind it. And I've been in all sorts of areas and neighborhoods, and you definitely see that, we are reaching more patients, and that's what's exciting to see.
It's wonderful. I got a question in the chat. For how long have you followed up your patients in clinical trials? Have you seen the effect of PGX on the risk of recurrence? So for the guided trial, we followed up with patients for 6 months. So after 8 weeks, we unblinded the patients, followed up with them for over 24 weeks. And we found that the effects of GeneSight in rates of remission continued to increase and actually doubled over time. You see a lot of times in clinical trials, a big complaint or frustration with trials is that they don't last long enough. And so we carried it on for 6 months, and we did see those effects continue to increase. There is another question specifically about guided, and I'm going to turn it over to Dr. Saulsberry. So does the guided study have a sham genetic test arm to assess for placebo effects? So basically, they want to know, if I'm telling patients that I have this objective evidence, what was the control in that study?
Gotcha. That's a really good question. So it did not have a sham report. That really wouldn't be that ethical to provide providers. So what we did is we actually compared that PGX or that GeneSight guided arm with treatment as usual. So really it was how you would treat a patient, but not having any genetic information to go off of, versus having that GeneSight report in front of you and having access to that. That was the difference in the two treatment arms.
Thank you so much. And we can also, so I know this was mentioned in the chat that we can share the poster from the APA with all of the people on the call. And we can also share some information generally about the guided trial, just so you can see kind of how that was set up and get some more details on that. I want to shift gears a little bit here. So in a GeneSight Cares webinar last year, Dr. Angela Shannon, who is a psychiatrist, told the audience that a widely understood and accepted fact is that Black men, particularly physically larger Black men, are often given significantly higher doses of medications. Dr. Williamson, have you heard of this phenomenon before? And does it seem like having GeneSight testing results could help remove the stigma or perception of this?
Well, thank you. Yes, I've seen this. I've heard of it. I've seen it in my own practice, encountering patients who've been under care of other providers. And you know, the best we understand about that, it relates back to a number of the studies around biases that we're unaware of, especially racial biases. And the idea here is that we typically we have a propensity to be more likely to perceive African American, especially males, as either bad or they can instill fear in people in ways that we don't perceive consciously, right? We've got probably, I think, 4 decades of studies that have substantiated that. So this isn't something that someone's necessarily thinking. It's a level deeper than that. And so how that can play out in these clinical encounters is, let's say a patient's paranoid. Well, a paranoid person might do any number of behaviors. So if I see someone as maybe more likely to be dangerous, or in my judgment, or I'm afraid they may do something and they're big, well, let me give them a good strong dose to keep everything under control. And that's an example of how, in my understanding and in my experience, how some folks end up receiving poor care, you know, higher doses than are effective, multiple medications and things of that nature. Now, a test like this, depending on how it's used, certainly has the possibility to try to cut into that and say, hey, okay, well, if we have this data, we know how this person metabolizes. Sure, brain sizes vary, but they don't vary that much. If someone's bigger, it doesn't mean that they need a bigger dose. And so I think with the objective data you can acquire through the GeneSight testing, I can imagine someone using that data to make a clinical choice in place of them using their own kind of subjective perspectives to decide where to start a particular patient as far as dose and number of medications.
And this, thank you for sharing that. This aligns nicely with the comment we got in the chat from a provider saying, when I discuss GeneSight's results with my patients, I emphasize they're called CYP genes. So there's 2 types of genes on the GeneSight report, and one of the types of genes we're talking about now are metabolism genes. The kind of slang term for them are called CYP or CYP genes, and this provides insight into how quickly or how slowly your patient may break down medications. And so when Dr. Williamson was giving his answer, this is what he was referring to. This provides objectivity in terms of how your patient will break down a medication and can help provide recommendations on potential dosing. So thank you for that comment from the audience. So Dr. Alva, I have a specific question for you, and I'm going to kind of walk around the panel with this one. So are there questions that you get from patients on genetic testing or GeneSight testing if you give it to them as a potential option? So are there different questions you get based on their ethnicity?
Yeah. First and foremost, people want to know, is this absolutely necessary, right? Why are we doing this? Is this something that we need to do? The answer is no, not really. You could not do it, right? We've not been able to do this. And in fact, there's a lot of people within the field that still feel that pharmacogenomic assays still have a long way to go. And the reality is that those individuals, I think, are not necessarily addressing the appropriate virtue associated with pharmacogenomic testing. This is not an end-all be-all test, right? And it is, as we stated previously, something that can help us out quite a bit. Dr. Williamson just made mention of the difference between a phenotype, what we're seeing, versus the genotype of the individual. And if we're able to peer through and take into consideration how somebody might respond to a particular pharmacological intervention, then that would make sense, right? And ultimately, all the themes that we're addressing right now apply to one thing, and that is, applying the golden rule. If we carry that forward to all the people that we encounter, we're going to be doing great. I don't think that pandering to the current lay of the land and paying lip service based on, the sway that occurs is the best way to go. But, if we really treat others the way that we would want to be treated, that's ultimately what's going to get us the best gain. And ultimately, the reason that we all went into this particular field is that we have this altruistic sense of wanting to help out our fellow individual, regardless of what they look like, regardless of what their backdrop is, and so on. We've been talking about the whole sense of equity of care, and that is literally laying before everybody the exact same opportunity of being able to thrive and lead as healthy of a life as possible. And, we all get one chance to ride. And if at the end of the day, you didn't enjoy the ride, it kind of falls back on you, but it also falls back on the professionals that were supposed to be there helping you out. So regardless of who it is that's asking me about this, I'll say, no, do you have to do this? No, you absolutely don't have to, but would it be a good idea for you to do so? Absolutely, and here's the reasons why, right? And as you lay those things down for people, you educate them appropriately, that helps out a lot. And Dr. Williamson pointed out that sometimes our bias is that, somebody based on how they look are going to be more violent or dangerous or otherwise. Well, again, that falls back on ignorance. And ultimately, what we're trying to do right now is dispel just that ignorance. And that falls across so many different areas. And in this case, right now, the stigma, the bias that resides on mental illness, we were comparing that with general medical conditions, it falls back on this. But I really see that a test like the GeneSight test is so critical and applicable within what we do on a day-to-day basis. So, yeah, in a nutshell, that kind of encompasses the majority of the thoughts around that and how to get that information across our patients.
I thank you for saying that so eloquently. I think it really sums up why we're talking about this as a health equity tool. You would want to know if this was an option or a test something for you. So the fact that it needs to be widely available to diverse populations really speaks to the health equity component. So thank you for that. Dr. Williamson, I'm going to turn it to you and ask the same question. Do you find that you have differences in response when you discuss genetic testing based on patient's ethnicity or background or gender, or do you feel like you get a pretty consistent response across the board?
It's interesting. I think I don't even remember encountering a negative response from anyone that I've offered this to. For different reasons and in different ways, I think people really appreciate any level of information that they can get. And, I think from a broader perspective, the mental health as a profession, within medicine, we lag behind the other areas of expertise as far as objective testing data and all of the things. And I think this is kind of a pioneering, endeavor to go into genomics, to objectively identifiable data, and to learn to use that to the benefit of the patient. And so I find that people are surprised that there's something objective, because I have a number of people that say, well, why wasn't this ever offered to me before? I've been in treatment for years. I've had multiple providers. And again, I think that's the responsibility, to piggyback on Dr. Alva's comment of the wider community of providers, to help, utilize the most objective data that we can have to make the best treatment choices for our patients. I will tell you that I did anticipate and do sometimes anticipate concerns about sharing genes, but I really haven't found people that was a barrier for them. I had one person tell me, well, you leave your DNA on everything you touch, right? I don't think it's that simple, but I was pleased to be, once letting folks know kind of everything that's entailed, and that it is using their DNA. I think people feel that their mental health is worth it, and so they enjoy the benefit of it.
Thank you. Dr. Saulsberry, I'm going to turn it to you. So Dr. Saulsberry, as I mentioned, works for the medical affairs team for Myriad Mental Health. And one of the things that I've heard consistently is the biggest barriers to implementing something like GeneSight or pharmacogenomic testing in general is lack of awareness. People don't know it exists. People don't know it's a tool. People don't know there's data behind it. So Dr. Saulsberry, can you maybe speak on that a little bit?
Yeah, I would also agree that is an issue. I know a lot of pharmacogenomic tests also, they're not advertised directly to patients. So that could be a reason why patients don't know they exist. But I think that's why it is important for the responsibility to fall on that provider. But I also think it's definitely a responsibility of the patient to take ownership of that journey, to seek out more information, to not let things like cost feel like a barrier, because I know that sometimes things can feel really expensive, but then when you look at the cost of what you're paying for your health, a lot of times it evens out. So just taking that ownership definitely can help address that. But then also just asking questions to your provider and asking, are there opportunities for me to engage in research or to try a new test, or what can help me on my journey? It's good to be proactive.
Yes, absolutely. Thank you for sharing that. And to Dr. Saulsberry's point, we do also have economic data supporting the utility of GeneSight, because cost is an understandable, inevitable topic that comes up. So I just wanted to point that out. And I think this also lends nicely to a comment that we got in the chat from one of the providers, discussing how the GeneSight tests can be different from other tests. So differences in test interpretation can be very confusing to providers and patients alike. So does Myriad align their recommendations with other groups and vice versa? And the short answer is no. So every test looks a little bit different. And it is very important that you question what the test is looking at in terms of what genes are on the report, the data supporting them. GeneSight differs from a group that was specifically asking this question called CPIC. They're an implementation consortium group, and their whole role is to try to help with the implementation of this as a tool. And that particular group focuses on single genes. So they look at two major genes and how those genes can affect medication outcomes. And our company, GeneSight, we focus on a combination of genes. It's called a combinatorial approach. So we focus on more genes at a time. So our test can look a little bit different than theirs, but as healthcare providers, as patients, it is well within your right to ask, why does this look different? What makes this test look different? One of the things I hear consistently from providers and scientists alike is not all genetic testing is created equally. So there is a little bit of homework and due diligence that needs to be done on that end as well. So, Dr. Williamson, I have a question for you. I want our listeners to leave here kind of with tangible nuggets to take away, tangible resources or approaches that they can use to help with this health inequity that we're seeing specifically in mental health care. So what are some resources or approaches that you use that can help healthcare providers in the audience provide equitable care across all of their patients?
You know, I think one of the differences with mental health compared to other fields is that the practitioner can be more of the tool. And I think the number one most significant thing a provider can do is to learn to identify their biases, to be open to the fact that we all have biases. Biases occur naturally. There's certainly patterns and stereotypes and things of that nature. But if we aren't engaging them and being aware of them and using them to keep them from impacting our choices and that we make for our patients, then I think we're doing a bit of a disservice. I mean, absolutely, objective testing is very helpful, whether it's GeneSight or other depression screens and things of that nature. So getting objective data is important. But at the end of the day, we have to use that data to make a decision, right? I think one of the other important things about GeneSight is that, take antidepressants, they're all statistically equally likely to work as far as percentage, right? So how do you choose one? Well, this is a tool that you can use to eliminate ones that may have a negative effect or may be less likely to work. So utilizing that data and doing that in a way that is similar and consistent across all patients. I think in the medical students and the other healthcare professionals that I teach and train, I tell them by the time you get ready to make a decision, look at the patient and ask yourself, if this was a loved one, would this be the choice that I would make? And so I think the things that we can do within ourselves to be aware that this is present in all of us, and to manage that and to be intentional about it. I think that's the biggest thing that can be done. And then secondly, of course, is the more objective, measurable, shareable information we have, so that we can make better decisions, and we can also involve the patient in the sharing of that information and in the choice of treatment options. I think the better.
Thank you. I think that's a really interesting point about how in mental health treatment, the provider acts as more of a tool than maybe in other fields of medicine. So it speaks to the training, it speaks to the, being aware of all these health inequities and how that can be a tool within itself. Dr. Alva, I'd like to pose the same question to you. Are there certain screening tools, websites, things that providers can turn to make sure that there is equitable care across different races, genders, et cetera?
Yeah, Dr. Williamson hit the head right on the nail right on the head. So long as people are competent about asking, what's the context of the social network of the individual, meaning their family, their friends, other people in their community, and so long as one is exploring what the individual feels is the cause of their problem, while having an understanding of their background or their identity and what's causing these problems, is really going to help in eroding those barriers that previously may have been there. That includes stigma or other areas where people aren't necessarily attaining the health or the care that they're seeking. I'd say probably the most important thing that we've been, kind of dancing around is really the concerns about differences in people's culture or background, and really the expectation of what a diagnosis and treatment might look like for them. In this is where this particular test, this GeneSight test, can be so critical and so influential in helping us propagate that additional information, education, and aid that people are seeking. So forums like this, I think, are really going to be useful in helping push the field forward, so that there's a greater understanding and a greater overall acceptance from a patient's perspective also, right? What I'm being handed is instrumental in helping me get better. So
Thank you.
wonderful to be here. Yeah.
I have a question that there may not be an answer to, and that's okay. I know, and people are very acutely aware of this now, that a lot of mental health is treated in primary care. They're kind of the first line treatment for awareness that maybe a mental health issue is developing or has already happened. And so what I've kind of heard in an undertone from Dr. Alva and Dr. Williamson is that one way to ensure equitable treatment of patients is to understand their culture, is to understand where they come from, to understand those nuances. How does that happen in primary care when time is not your friend, when they're seeing many, many patients a day for many, many things? How can that be translated into the primary care setting?
Well, that's an easy one.
I don't want to end on a
Well,
difficult one here.
I think this is something that we probably don't have a shortcut for. I think that certainly in the way that we provide care, there's limited time, there's multiple visits. Typically, these things can be done over several visits. It doesn't have to be done all at once. And I think it has a lot to do with how you see your patients. I mean, if we're treating a condition and we're not asking the person how the condition affects their life, I think we're probably missing something. And so I think there are ways to create efficiencies and getting a richer history and understanding of the patient experience, which should aid in more effective outcomes. But it just has to be on the list of things that you value as meaningful and helpful information about the patient to make a clinical decision. I mean, there are many models that include social workers and other things, and I think those can be very helpful. But if we're talking about the provider, the clinician making a choice, that information has to be owned by that person that has the responsibility and the training to make that choice. So some of this is incumbent upon us as providers to take the time and do due diligence to seek out.
Yeah. And, again, in defense of our primary care brethren, they do have to know a little about a lot of different things, right?
Yeah.
And so, Dr. Williamson was, trying to be, again, somewhat zestful with the whole, that's an easy one, right? But in reality, I think that his solution that he presented right now is really critical. You do things snippets at a time, right? Little chunks, and over time, you can actually get all of that work accomplished. But it does take a very thoughtful perspective to be able to do just that.
And I'll add,
right?
Oh, please.
Yeah.
No, I was just going to add that one of the additional challenges in all that we're talking about is that healthcare is designed that the encounters are short. They're shorter than they used to be, and it provides more care. It's effective, right? But that makes it that much harder. It does. Whether we're talking about gathering information or even checking our own biases or ordering a test or walking a patient through a GeneSight test, right? All of it does take more time, but I do think in the long run it saves time and it creates more effective treatment and more effective care. So sometimes we have to reprioritize how we used to do things to newer technologies that we can integrate to make our practices more effective.
Absolutely.
I will say, however, that, when you take a look at, for example, this GeneSight test, when you create that analogy of like a traffic light scenario, green, yellow, red, where you can go, and then subsequently make the appropriate interpretations that, what, red doesn't necessarily mean you can't. It just means you're going to be exhausting other things first before you're actually stepping into this particular arena. I think is a very easy concept for most people to grasp, look at, and be able to digest, right? As opposed to, a Pyrrhus Fabers, where you've got like this massive document. It's like, well, how do I interpret this, right? For most people, that would be, an insurmountable type of a task. But with this, you make things easy, not to the point of, again, dumbing it down, but just making it easily digestible. And I think that people really do like that. And that includes a lot of clinicians.
Okay, it sounds, my big takeaway is that this in primary care and in all practices will come from a top-down approach of training to be thoughtful, to think about these questions. I think one of the biggest steps forward that we've made is we're having these conversations. It's making people aware they need to ask these questions. So I know we are right at 8 p.m. I want to be respectful of everyone's time. The last thing I will ask Dr. Saulsberry to sum up in 15 seconds or less, where can people find more information about GeneSight?
Yes, well, the easiest response to that is genesight.com. So make sure you check it out. There's lots of resources for both patients and clinicians.
Wonderful. That was literally under 15 seconds. So well done. Thank you to everyone who attended tonight. We sincerely appreciate it. If there were any questions, I think there were a few that I did not get to in the chat, we will reach back out to you and provide answers for them. Thank you to our wonderful panelists for all of your incredible insights. I've learned a lot. I know everyone on this call has. So I hope everyone has a wonderful rest of your night, and thank you for your time.
Thank you
for having us.